Disorders of eyelids. Let's see the gross anatomy. The gross anatomy of eyelid. This is internal margin strip, dorsal portion, upper palpable furrow, upper punctum, lower punctum, openings of dorsal glands, lower palpable furrow, orbital portion. The eyelids are mobile tissue contained placed in front of eyeballs. These act as shutters protecting the eyes from injuries and excessive light. These are also perform an important function of spreading the tear film over cornea and conjunctiva, also helping drainage of tears in lacrimal system. The parts are each eyelid is divided into horizontal and divided by horizontal furrow into an orbital and dorsal parts. Position of lids. When the eye is open, the upper lid covers about 1/6 of the cornea. Lower lid touches the limbus. Then the canthi. The two lids meet each other at medial and lateral angles. In Caucasians with the lids open, the lateral canthus is about 2 mm higher than medial canthus. Palpable aperture. It is the elliptical space between the upper and lower lid. When the eyes are open, it measures about 10 to 11 mm vertically in the center, about 28 to 30 mm horizontally. Lid margin. It is about 2 mm broad and is divided into two parts of punctum. The medial and lacrimal portion is rounded and devoid of laser glands. The lateral ciliary portion consists of a rounded anterior border, a sharp posterior border, and an intermarginal strip. The gray line divides the intermarginal strip into an anterior strip and bearing 2 to 3 rows of lashes. The layers of striated muscle present are the main muscle present is orbicularis oculi muscle, which forms an oval sheath around the lids. It comprises of 3 portions: the orbital part, palpable part, and lacrimal part. The palpable part is divided into pretarsal and preseptal parts. It closes the eyelids and is supplied by zygomatic branch of facial nerve. Therefore, in paralysis of facial nerve, there occurs lag ophthalmos. Lag ophthalmos, which may be complicated by exposure characteristic. Lag ophthalmos we'll see in the future. In addition, the upper lid also contains the levator palpebris superioris muscle, LPS. It is another muscle present. It arises from the apex of orbit and is inserted by 3 parts on the skin of lid: anterior surface of dorsal plate, conjunctiva of superior pharynx. Then we'll move on to blepharitis. Blepharitis is a subacute chronic inflammation of lid margins. It is subacute chronic inflammation, not acute, subacute or chronic inflammation of lid margins. This one is bacterial blepharitis. It is an extremely common disease which can be divided into following clinical types: bacterial, seborrheic, mixed cephalic or seborrheic blepharitis, posterior blepharitis or meibomitis, parasitic blepharitis. Then bacterial blepharitis. Bacterial blepharitis, also known as chronic anterior blepharitis or ulcerative blepharitis, staphylococcal blepharitis, etc., is a chronic infection of the anterior part of lid margin. It is a common cause of ocular discomfort and irritation. It usually starts in childhood. Etiology: causative organism Staphylococcus, rarely Streptococcus, Propionibacterium acnes, Moraxella. Predisposing factors are usually none, may rarely include chronic conjunctivitis, dacryocystitis, etc. Clinical features: symptoms include chronic irritation, itching, mild lacrimation, gluing of cilia, mild photophobia. The symptoms are characteristically worse in morning. Remission and exacerbation are quite common. Signs: yellow crusts, small ulcers, red thickened lid margins, mild papillary conjunctivitis, conjunctival hyperemia are common associations. Small ulcers which bleed easily are seen in removing crusts. Yellow crusts are seen at the root of cilia which glue them together. Then tylosis, thickening and scarring of lid margin, eversion of punctum. Then eczema of skin and ectropia, recurrent ties, marginal keratitis, occasionally flectinulosis may develop. Tear film instability, dry eye may result. Secondary inflammatory and mechanical changes in the conjunctiva and cornea are common because of intimate relationship between lid margin and ocular surface. Treatment: bacterial blepharitis should be treated promptly as below to avoid complications equally. Lid hygiene is essentially at least twice daily and should include warm compress for 5 to 10 minutes to soften the crust. Crust removal, avoid rubbing of the eyes or fingering the lids. Antibiotic eye ointment should be applied at the lid margin immediately after removal of the crust. Antibiotic eye drops should be used 3 to 4 times a day. Oral antibiotics such as erythromycin, doxycycline may be useful in unresponsive patients and those complicated by external hordeola and absence of lash follicle. Topical steroids such as fluoromethanolone may be required in patients with papillary conjunctivitis, marginal keratitis, and flectanulosis. Ocular lubricants. Artificial teardrops are required for associated tear film instability in dry eye. Then seborrheic is primarily anterior blepharitis with some spillover posteriorly. Then posterior blepharitis, meibomitis, meibomian gland inflammation, chronic meibomitis, and acute meibomitis. Here also treatment lid hygiene maintain warm compress, topical antibiotics, systemic tetracycline, ocular lubricants, parasitic blepharitis. It's another condition, lash infestation. It's caused due to Thyriasis, palpable pediculosis. Similar clinical features are seen external hordeum styli. External hordeum styli. It is an acute separated inflammation of lash follicle and is associated with glands of J's or mole. This is Thyriasis palpebrum. It is parasitic blepharitis. Etiology of external hordeolum. Predisposing factors are age, more common in children and young adults, habitual rubbing of eyes or fingering the lids and nose, chronic blepharitis and diabetes mellitus are usually associated with the current stage. Metabolic factors, chronic debility, excessive intake of carbohydrates and alcohol also act as predisposing factors. Causative organisms commonly known as Staphylococcus aureus. Clinical features, symptoms include acute pain associated with swelling of lid, mild watering, photophobia. Signs are stage of cellulitis, stage of abscess. Stage of cellulitis is characterized by localized firm red tender swelling at the lid margin associated with marked edema. Figure 15.11. Hordeolum externum, upper lid. Stage of abscess formation characterized by visible pus point on the lid margin in relation to affected cilia. Treatment: hot compress 2 to 3 times a day are very useful, especially in cellulitis stage. Evacuation of pus should be done by epilating the involved cilia when the pus point is formed. Surgical incision required rarely for a large abscess. Antibiotic eye drops and eye ointment should be applied to control the infection. Systemic anti-inflammatory analgesic relieve pain and reduce edema. Systemic antibiotics should be used for early control of infection. Chalazion also called tarsal meibomian cyst is a chronic non-infective non-suppurative inflammation of meibomian gland. Commonest of all lid lumps. Etiology similar to hordeolum externum. Pathogenesis very low virulent organisms. Consequently, there occurs proliferation of epithelium and infiltration of walls of ducts which are blocked. Consequently, there occurs retention of secretion sebum in the gland, causing its enlargement. The pent up and extravasous secretions act like irritant, excite non-inflammatory lipogranulomatous inflammation of blocked meibomian glands. Clinical features: painless swelling, mild heaviness, blurred vision, watering before, etc. Signs: nodules noted slightly away from the lid margin, which is firm to hard, non-tender on palpation. Upper lid is involved more commonly than lower lid, probably because of the fact that upper lid contains more meibomian glands than lower lid. Reddish purple area. This is chalazion of upper lid. It is done by incision. It is removed by incision curettage of chalazion from conjunctival site. Reddish purple area where chalazion usually points is seen on palpable conjunctiva after evasion of lid. Projection of main bulk of the swelling on the skin side may be rarely instead of conjunctival side. Margin chalazion occurring occasionally may present as small reddish grey nodule on lid margin. Clinical course and complications. Complete spontaneous resolution may occur rarely. Slow increase in size is often seen. Eventually, it may become very large. Fungating mass of granulating tissue. Secondary infection may lead to formation of hordeolum internum. Then calcification may occur, though very rarely. Malignant change into meibomian gland adenocarcinoma cancer. Treatment: conservative treatment, self-resolution, intralesional injection, incision and curettage, etc. Diathermy can be done. Internal hordeolum. It is a separate inflammation of meibomian gland associated with blockage of duct. Predisposing factors are similar to hordeolum externum. Causative mechanism: primary staphylococcal infection of meibomian gland or due to secondary infection. Then clinical feature: symptoms include acute pain very acute pain associated with swelling of lid, mild watering and photophobia. Thus, symptoms are similar to audiolum externum, except that pain is more intense due to swelling because embedded deeply in the dense fibrous tissue. Signs include a localized foam red tender swelling of the lid associated with marked edema. On examination, audiolum internam can be differentiated into audiolum externum by fact that in it the point of maximum tenderness and swelling is away from the lid margin. That pus usually points on dorsal conjunctiva, not on the root of cilia. Sometimes pus point may be seen on the opening of involved meibomian gland and rarely on the skin. Treatment is similar to audiolum externum, except that when pus is formed, it should be drained by vertical incision from the dorsal conjunctiva. This is audiolum internum of lower eyelid. Then entropion refers to inward rolling and rotation of lid margin towards globe. Etiological types, two types I think, congenital entropion, cicatricial entropion, senile entropion, and mechanical entropion. Congenital entropion is a rare condition seen more commonly in lower than upper eyelid. Lower eyelid congenital entropion is caused by improper development of lower lid retractors. Upper eyelid congenital entropion is usually secondary to mechanical effects of microphthalmos. Cicatricial entropion is a commonly variety, usually involving the upper eyelid. It is caused by cicatricial contraction of palpable conjunctiva with or without associated distortion of tarsal plate. Common causes are trachoma, membranous conjunctivitis, chemical burns, pemphigus, Stevens-Johnson syndrome. Cicatricial entropion. Senile entropion is a common occurrence and affects only the lower lid in elder people. Etiological factors which contribute for its development are horizontal laxity of lid due to weakening of orbital muscle, vertical lid instability due to weakening or dehiscence of capsulopalpal fascia, overheating of pretarsal orbicularis, degeneration of purple connective tissue separates the orbital muscle fibers and thus allow the precellular fibers to override the pretarsal fibers and thus tipping the lid margin inwards. Laxity of orbital septum along with prolapse of orbital fat into lower lid also contribute to inward rolling of lid margin. Mechanical entropion occurs due to lack of support provided by the globe to let's say. Therefore, it may be occur in patient thisis bulbi enophthalmos after inoculation of evisceration of operation. Clinical features: symptoms occur due to rubbing of cilia against the cornea and conjunctiva are thus similar to trichiasis. These include foreign body sensation, irritation, lacrimation, photophobia. Signs are as follows: interning of lid margins, signs of causative disease, signs of complications. Signs are as follows: interning of lid margin. On exam, lid margin is found interned. Depending upon the degree of interning, it can be divided into 3 stages: grade 1, grade 2, grade 3. Grade 1 only posterior lid border is enrolled. Grade 2 includes interning up to internal margin strip. Grade 3 in which whole lid margin including anterior body is interned. Signs of causative disease: exam scarring of palpable conjunctiva and cicatricial entropion, horizontal lid laxity in involution entropion. Signs of complication may include recurrent corneal aberration, superficial corneal opacity, corneal vascularization, even corneal ulceration. Treatment: congenital entropion may resolve with time without need of any intervention or may require excision of a strip skin and muscle with plastic reconstruction of the lid. Cicatricial entropion, it is treated by plastic operation. Then anterior laminar resection, it is simplest operation employed by to correct mild degree of entropion. Tarsal resection, it corrects moderate degree of entropion associated with atrophic tarsus. In this operation, in addition to elliptical resection of skin and muscle, a wedge of tarsal plate is also removed. Transposition of torso-congenital wedge, modified Ketsi operation. This is indicated to treat mild to moderate amount of cicatricial entropion. Then tarsal wedge resection, tarsal wedge shaped resection, and then transverse lid everting sutures, diagrammatic section and frontal view to show the posture of sutures. This one transposition of torso-congenital wedge transposition. Then plication of lower lid retractors, front view and cut section. Weiss operation. Then ectropion, outrolling or outward turning, etiological type congenital, involutional, cicatricial, paralytic, mechanical. Clinical features: symptom epiphora is main symptom in ectropion. Symptoms due to associated chronic conjunctivitis include irritation, discomfort, mild photophobia. Signs: lid margin is outrolled. Signs of etiological conditions: grade 1 In it only punctum is everted. Grade 2 lid margin is everted. Grade 3 fornix is also visible. Skins are in schizoidal ectropion. 7th nerve pulse is paralytic ectropion may also be seen. Involution ectropion. One or more of the following signs can be horizontal lid laxity, medial canthal tendon laxity, lateral canthal tendon. Complication: dryness and thickening of conjunctiva, corneal ulceration, eczema, dermatitis. Treatment: congenital ectropion, involution ectropion. Involution ectropion A and B is schizoidal ectropion lower lided. A is 2 vertical incision for horizontal lid shortening and horizontal slit incision. B is passage of lid vertic suture after completing of horizontal lid resection. C is final position of sutures. Medial conjunctivoplasty, modified Kuntz Szymanowski operation. Then we'll move on to Blepharitis. In this condition, lid becomes adherent with eyeball as a result of adhesion between palpable and bulbar conjunctiva. Etiology: it results from VO operation, horizontal lid shortening. It results from kissing raw surface upon the palpable and bulbar conjunctiva. Common cause: thermal chemical burns, membranous conjunctivitis, injuries. Steven Johnson. Clinical feature: ocular movements become restricted, diplopia, lack of thermus, cosmetic disfigurement. Types: anterior, posterior, total. Treatment: sweeping glass rod coated with lubricant around furnaces several times a day. Therapeutic: soft contact lens. Curative treatment: mobilizing surrounding conjunctiva in mild cases, congenital buccal mucosa graft, amniotic membrane transplantation. Blepharitis. It refers to adhesion between margins of upper and lower lids. Blepharitis, diagrammatic definition: anterior, posterior, and total Blepharitis. Lack of ophthalmos. Lack of ophthalmos is a condition is caused by inability to close the eyelids voluntarily. Etiology: it occurs in patient with paralysis of orbital ocular muscle. Cicatricial contraction of lids. Blepharitis, severe ectropion proptosis following over restriction of levator muscle for ptosis in comatose patient. Clinical feature: it is caused by incomplete closure of palpable aperture associated with features of causative disease. Complications include congenital corneal cirrhosis, exposure keratitis. Treatment: artificial teardrops of soft bandage contractors, torsography. Then there are two types of torsography: temporary torsography and permanent torsography. Ptosis is the abnormally drooping of eyelid is called ptosis. Normal upper lid covers the upper 1/6 of cornea, about 2 mm. Therefore, in ptosis it covers than 2 mm. Congenital ptosis is simple and blepharophimosis syndrome. Clinical etiology type: congenital. Then acquired. In acquired neurological ptosis, acquired myogenic ptosis, aponeurotic ptosis, mechanical ptosis. Clinical evaluation history: examination exclude pseudoptosis, measurement of degree of ptosis in millimeters. Observe the following points in each case: whether unilateral, bilateral, causes of bilaterosis, myasthenia gravis, myotonic dystrophy, Kuntz-Seyre syndrome, function of ocular muscle, measurement of amount of ptosis, margin reflex disease, access of levator function. Treatment of congenital ptosis: torsocongenital mullerectomy, Fasanella servet operation, levator resection. Amount of levator resection required are most of the surgeons find it out by adjusting the lid margin in relation to cornea during operation on the table in individual case. Techniques: congenital approach, skin approach, frontalis sting operation, Fasanella servet. It is torso-conjunctival mullerectomy. Then congenital approach for levator resection, skin approach for levator resection, frontalis sling operation. Tumors of eyelid: mostly they are classified benign, precancerous and cancerous. Benign, mostly papillomas, xanthellisa, capillary hemangioma. Hemangioma is classified into capillary, nevus and cavernous hemangioma. Neurofibroma, it is differential diagnosis for scalacion, keratoacanthomas, then navy, then prenatal tumor, actinic keratosis, xeroderma pigmentosa, malignant tumor, basal cell carcinoma, Then basal cell carcinoma is most costly due to non-ulcerative nodular formation, sclerosing or morphea type, pigmented basal cell carcinoma, nodular ulcerative basal cell carcinoma, basal cell carcinoma, lower eyelid, divided navy of eyelids, meibomian gland carcinoma, squamous cell carcinoma of upper lid, malignant melanoma, sebaceous gland carcinoma, and etc. So